Hello, everyone. Great to see such a great participation. It's a real privilege to be teaching you guys. My name's Shinmei. I'm a honorary consultant at St Mary's Hospital in Paddington, and but my main job is as an academic. So I work at the London School of Hygiene and Tropical Medicine, and I was just made a professor a couple of weeks ago. So I've just changed my title from associate professor to professor, which is very exciting. Right, and my main work has been in malaria up until quite recently, so that's what I thought I should talk about. So just to start off with, just a quick quiz, just to get a sense of what people's kind of background knowledge is like. So approximately how many people do you think are going to die of malaria between the start and end of this talk? And just kind of, an A, B, C, and you can just, you can either just kind of add your thoughts in the chat, or just kind of write it down on a piece of paper. Just what kind of malaria can cause relapse? So what kind of types of malaria do you know about? And of those, which ones do you think can cause a relapse? Someone's taking a guess at falciparum. I'll give you a couple of seconds to think about it. Ovale, Vivax. Okay, I'm liking some of these question results I'm seeing. Okay, third question. So we're getting a nice kind of combination there. I think you guys seem to know quite a lot already. Name two types of diagnostic tests used in clinical practice, and one for surveillance and elimination. So ICT, so immunochromogenic thick film. Yep, great. All right. BFFM. Okay, and how about for surveillance and elimination? Okay. Now, this one I hope you get. What is the first-line antimalarial treatment for severe malaria? Okay, we're getting a combination, a few quinines, artesunate, artemether, mainly artesunate, great. And what is the epicenter of antimalarial drug resistance? All right, okay, so we'll come back to these at the very end, Southeast Asia, and see how many you got right. So I'm hoping through this session, we can, I'll start with a very quick case study, and then hopefully by the end of it, we'll have reminded ourselves of the basic biology and epidemiology of malaria. And then I wanted to give an update on kind of diagnosis, on treatment, and drug resistance, because that's what I have been working on for some time. And if we have time, maybe talking a little bit more about the kind of global context in malaria elimination. So let's just start with William. So imagine that we are in West Africa. This is William, as a little 9-month-old boy with 3 days of fever, decreased feeding, and excess crying. And he's got a 2-year-old brother and a 4-year-old sister. So, and the nearest health centre is 5 hours walk away. So this is pretty typical in terms of what we. Oh, can you not see the slides? Oh. It's just the title. Oh. Could you see my slides earlier? That's very odd. No. Oh, right. Oh.
Dr. Yeung, can you please press the slideshow button?
Yeah, I've got slide share.
Yeah, that's done.
Sorry, I thought I was sharing them all along, but obviously not. Here. Do you see it now?
This conference will now be recorded.
I'm really
Can
sorry
you
about that.
please press the slideshow button, the right lower
I mean,
slideshow?
you can see my screen now, can you?
Yeah, I can see your screen, but
How about that? Now?
the first screen only.
Oh no, this is so frustrating. Okay, let me just
Shinmei, sorry, we can see your screen. Yeah, I think it's just that button down there.
have you got it now? Yes, can you see it?
No, if you click, we can see the program, the PowerPoint program. You just need to click start slideshow. You had your mouse just over it a second ago.
Oh,
So just
that's really
just
weird, 'cause
below that side at the bottom. That yeah, try that
But
one.
that's when I click onto it though.
It doesn't
Right,
show.
so now, do you see what I see? I see William.
We can just see the PowerPoint program itself and not the full screen slide.
Because so you see things as soon as I click onto that, it disappears, which is really
It's frustrating. One sec.
the other thing is, unless I could ping it to someone, and because I wonder if it's okay. You know what? I'm going to try this. I'm going to try sharing my screen. See my screen now?
We can see your screen.
Okay, great. All right. I think I was trying
now.
Perfect.
That's it.
Yeah,
It's
great. Okay, good. Sorry about that, guys. I think it was I was trying to do it in the application. Right. So this is back to William. So you see, I had all this stuff. You know, this is all that. So you guys did very well with the quiz without seeing the questions. So this is William. He is a 9-month-old boy with 3 days fever, decreased feeding, excess crying. He's got a 2-year-old brother and 4-year-old sister, and they live quite far away from the nearest health centre. So Mum has to make a decision about whether she's going to leave home and leave the 2 kids at home, or just try and manage William herself. So she gives him some paracetamol and chloroquine, but he doesn't get any better. Can you? Oh, I'm going to shrink this. Oh, what have I just done? So she asked the neighbour for some medicines, and the neighbour gives him amoxicillin. So this is not, this is not unusual. William still doesn't get any better, so she decides to come to the nearby, goes to the health centre, and you happen to be at the health centre, and this is what you see when William arrives. And there should be a... So what are you seeing there? What do you think is going on? Okay, I can't see, I'm not going to try and see your responses. So what do you do? So obviously William's fitting, and so you do your ABC, you follow APLS, and you try to stop the fits with whatever's available. And then in that circumstance, it may well be something like rectal diazepam. So what investigations would you do? So I'm hoping that you would have thought about doing some of these. So a blood film, rapid diagnostic test for malaria, and I guess what is in this list will depend on where you are. If you are seeing this child obviously in the UK, then hopefully you'll be able to carry out most of these tests. In somewhere like West Africa, you may be able to do only a handful. For example, the rapid diagnostic test, and maybe a dipstick for the blood glucose. I'm going to come back, I can come back to this a little bit later in terms of what the features are of severe malaria. But just as a hint, some of the reasons why you're doing this is to get an indication of how what you can do with William immediately, in terms of giving him glucose? Do you need to and a prognosis and getting a sense of, is he someone who's going to develop severe malaria? So his results come back like this. His hemoglobin is 6.5. That's his rapid diagnostic test. This is his microscopy. And actually, this is actually from another patient. So in reality, you're probably very unlikely, you probably only see this. You probably only see on the right-hand side, you'd probably only have falciparum and not vivax as well. And he's got 4% parasitemia. So how would you treat him? I'm going to try and, I know I'm showing my screen, but I do actually want to see what you are saying. So let me see if I can. Okay, great. So lots of you said, he's seizing, he's got glucose. Now, is this working? Can you see, are you seeing the screen? You're still seeing the slideshow? Okay, yeah, right. So what would you give him? So a lot of people are saying IV quinine. So actually, so Nola's saying admits, transfuse, Paxil, start IV fluids, IV artesunate. Any dark urine, don't know about the urine, he hasn't passed urine for a while. Supportive care, Okay, so I'm going to flick back to this. So I'm hoping that most of you would have given him IV artesunate. And we're going to come back to why. So next. I'm sorry, I'm really struggling with this technology here, isn't it? So just going back to kind of some basics in terms of malaria, and I'm hoping this is going to work. Just want to show you, just go through the life cycle of malaria. This is quite a nice video.
So I saw in your profile that you like to cook.
Oh, I love it. This is my specialty.
Ooh, thanks.
Oh, you ate it already.
I was really.
The malaria parasite is an ancient organism. It has been with us since before we were human. Famous victims include Alexander the Great.
Actually, sorry, cut. This is what I wanted to show you. So I'm going to give a voiceover. So just to remind you, so malaria is transmitted by the female Anopheles mosquito. And what she does is when she's probing into a capillary, she releases saliva into the blood vessel and releases the little wormy things, which are the malaria sporozoites. They travel in the bloodstream straight away to the liver. And when they get to the liver, they invade hepatocytes. So at this point, the patient is asymptomatic because the parasites have gone straight into the liver. They're not actually circulating in the blood. And it is a little bit alien-like. So the sporozoites kind of burrow their way through into the hepatocytes. And then within the hepatocytes, they start to multiply. So they transform. Multiply until there's about up to, can't remember, but it's a huge number within the hepatocytes. And then they burst out of the hepatocyte. And this is like in the tens, almost per hepatocyte. And this form, which is the merozoites, then get into the bloodstream, and each of them invades the red blood cell. So this is a merozoite, and it's got that spiky bit. It's penetrating into a red blood cell. And then within the red blood cell, it multiplies. So once it's penetrated into a red blood cell, the cycle within the red cell is about 48 hours. So it multiplies till about 10 more parasites. And you can see it's transforming the shape of the red cell, making it very sticky. That becomes relevant later. It means it sticks to the kind of sides of capillaries. And eventually, this is at the schizont, a mature stage, it bursts. And this is where it's very alien-like. And then each of those then penetrates through into another red blood cell. So every 48 hours, so if it gets into this kind of cycle of all the blood cell, all the parasites doing the same thing at the same time, you get this 48-hour cycle with a kind of 10-fold increase in the number of parasite infected blood cells. So that kind of explains a little bit the kind of the pattern of symptoms that you see. So going back. And each of there's five malaria parasites, and they all each behave a little bit differently. So the ones that you really have to worry about are, I think, the two on the left. So P. falciparum, and that's the predominant species that you see in Africa. So most of the malaria in Africa is falciparum, and most of the falciparum is in Africa. But you also find it in Asia. But in Asia, you also get other species. And it's the most important because it's the one that really causes all the severe disease and all the mortality. Although you do get some severe disease also in vivax. Now, vivax is only really found in Asia and in the Americas. It's not found in Africa, which is why that earlier slide was a bit confusing. Sorry about that. And the relevant thing about vivax, it has a form in the liver, which just stays in the liver, so hypnozoites, so they sleep in the liver and they can stay there for weeks, months before being reactivated and going into the bloodstream and causing a recrudescence. And as I said, it can occasionally also cause severe malaria. There are different types of vivax, and some of them are some different strains, and some of them seem to cause more severe disease and more frequent relapses, for example, in Southeast Asia, compared to, for example, the strain that's found in the Mediterranean, which relapses much less frequency and tends not to give a severe picture. Ebola is pretty uncommon, but can also cause relapse. Malaria is also pretty uncommon and can cause a chronic infection. And the final one's an interesting one, Nolazai, which is quite recently discovered. And it's mainly found in where there are macaque monkeys, who are the primary host, and that's in Malaysia and the Philippines. So the types of, when you get malaria and then get another episode of malaria, that can happen for a couple of reasons. One, and the most common, is probably recrudescence. So that's when the original infection has not gone away completely. And that might be because of drug resistance, poor quality drugs, or a number of other reasons. The second reason is relapse, and that's where that relates to the question is, and that's where you have these hypnozoites, these forms that sleep in the liver and come back to life at some point. And finally, reinfection. So in a place where there's lots of mosquitoes which are infected with malaria, and you keep getting bitten again, reinfection. This map is from a lovely website called the Malaria Atlas Project in Oxford, where they've got very frequently updated maps of malaria epidemiology. This is a heat map of falciparum malaria, and you can see the place where it's affecting is really Africa, and in particular sub-Saharan Africa, and that kind of strip of West Africa. But you can see it's also in Southeast Asia and in the Americas. Now this map shows two things. It's a map of vivax, so the kind of the deep shading is of vivax, and what is notable is that there is very little vivax in Africa. There's very little. There's areas in Africa which have not got vivax, and that's partly in relationship to the presence of Duffy antigen. So it seems to be absent in lots of the African population, and it's probably needed as a receptor for P. vivax. So malaria numbers. And I wanted to try and kind of compare it to what we're seeing in COVID. So last week was malaria. There was a World Malaria Day, and there was quite a lot of kind of attention in terms of what is going to happen with malaria, given the measures and with COVID-19. And I think there's real concerns in the malaria world that we're going to see a resurgence of malaria, because so many of the activities that are necessary to kind of keep malaria under control, we're not able to carry out. So there's a loss of malaria, but we've made great inroads, I think, in the last 15 years. So a huge reduction in deaths from malaria kind of in the last 15 years due to a couple of measures, which I'll talk about in a minute. So this is trying to show the kind of reduction in malaria since 2000. So since 2000, there were over 1 million deaths before that due to malaria. And over the last 15 years, we've seen a big reduction. And that's mainly due to a couple of key interventions. One is insecticide-treated nets. So there's been a massive upscaling of insecticide-treated nets across sub-Saharan Africa. And the second thing is, so that's indicated by the grey bars. And the second thing is ACTs, that's Artemisin combination therapies, which I'm going to talk about next, which is the much more effective treatment for malaria than what was available before. And the dark bars out there are indoor residual spraying. So a lot of the kind of malaria control, a lot of the reduction in malaria has been due to prevention has been due to prevention with bed nets and IRS. So kind of going through kind of the clinical features, and I think most of this will be quite familiar to you, so I'll go through it quite quickly. So the incubation period is usually around 10 to 15 days, and that's related to the malaria cycle, as we saw earlier. Uncomplicated malaria looks very much like any other non-specific febrile illness, so fever, rigors, headache, lethargy, so like a bad flu. The things that kind of characterize severe malaria are, this is for epidemiological purposes, but can also help with you clinically. So impaired consciousness, prostration, in children, failure to feed, convulsions, acidotic breathing, shock, jaundice, black urine, so hemoglobinuria. You can get a clotting disorder and pulmonary edema. In terms of lab results, hypoglycemia is common, a metabolic acidosis, obviously a severe anemia, and then a hyperparasitemia. So depending on whether you're in a low transmission or a high transmission setting, the level of parasitemia that you can tolerate is different because of the level of immunity. So if you're in an immune setting and you have some immunity, then you are able to tolerate a higher parasitemia. A high lactate is one of the best, one of the, I should say, most accurate kind of prognostic features for developing severe malaria. So who gets severe malaria? And it's largely children and pregnant women. And I'm going to be not talking too much about pregnant women, so I just wanted to kind of flag up here what the risks are for pregnant women in pregnancy. So the woman herself is much more vulnerable to severe malaria and getting a severe anemia. There's also the adverse outcomes in terms of spontaneous abortion, stillbirth, and prematurity. But the most common, the one that we're most aware of, is low birth weight, and then the important impacts afterwards in terms of low birth weight. So just a slide or two about why you get severe malaria and how it's kind of working. So we saw earlier in the film about how the red blood cells that get invaded by the parasites change. They destroy the red blood cells, so they cause that severe anemia, and they also change shape that makes them very sticky. So they end up getting sequestered, so they get stuck in small blood vessels, particularly in the brain and the placenta. And they also, sorry, I'm going to go back there. And there's also a huge cytokine storm, so you get a lot of inflammation and endothelial damage. And how that then manifests clinically depends a little bit on the age at which you get severe malaria. So in the younger children, it usually manifests as a very severe anemia. And then as they get older, you see more cerebral malaria. This is in children. In Asia, where the immunity is less, you don't get malaria in kids very much. You don't, sorry, the transmission is less. It's mainly adults who are exposed by going to where there is malaria, who get, so in the forest, who then don't have an immunity and then develop a different picture for severe malaria than you see in severe malaria in children. So in adults, you tend to get a picture of renal failure and a lot of multi-organ dysfunction, including respiratory. In children, it's really the severe malaria and the severe anemia and the cerebral malaria. So this is some nice pictures which kind of show those infected red cells getting stuck in small capillaries, and that's in the brain, in the lung, in fatty tissue, and you also see the same picture if you look at the placenta. So that's kind of why you get the low blood flow going into the fetus and resulting in the stillbirths, the abortions, and the low birth weights. And as I said, you also get a cytokine storm with high TNF, TNF alpha. So malaria parasites is really clever. It's been around for a lot longer than humans has, and it's learnt to adapt to evade the human immune system. So by replicating within red cells, it means that it's actually relatively protected from the immune system. It also has a very variable expression of antigens on the red blood cell surface, and it can switch that very quickly. So it makes it really difficult to develop immunity to malaria, and also makes it very difficult to develop a vaccine. As I said, it's been around a long time, and it is the single microorganism which has exerted the greatest selective pressure on our human genome. It's why we have things like sickle cell trait and thalassemias and G6PD deficiency. Obviously, having something like, as I think most of you will know, having sickle cell disease limits your life expectancy. But having sickle trait, when there's malaria around, confers enough benefit that means that the genetic condition has prevailed. I hope that's clear. I should probably stop at some chance and give you guys an opportunity to ask questions, but I'm just going to fire on. So I've kind of talked a little bit about diagnosis and treatment and the pathophysiology, and I want to talk a little bit about drug resistance. What are we doing for time? Oh, do I? No, I want to talk about diagnosis. So talking about diagnosis, clinical presumptive diagnosis is how the majority of children were being diagnosed before, because microscopy, which is what was available, requires equipment, supplies, training, is quite operator dependent and can take quite a long time. The advantage is you can quantify, so you can see what the parasitemia is. You can differentiate between different types of species, and you can stage, which means you can see if it's an early stage. So you've got lots of ones which are lots of parasite cells, but they're not yet the mature ones with the schizonts, or you can see if there are lots of schizonts, so the kind of the ones with lots of parasites in which are about to burst. And you can. What's going to transform the diagnostic landscape is the rapid diagnostic test, or here we know it as the immunochromogenic test. So it's an antigen test, and there's two types of antigen. One is the HRP2, which you only get in Falciparum, or a pan-specific antigen, which is the parasite LDH, and that you get in all types of parasites. Most of the tests that we use here in the UK are have both. So it enables you to look at, see whether it's PF and or whether there's, it allows you to see if there is PF there, and can also indicate whether you have a mixed infection. They're really easy to use, so we use them very widely in Africa and Asia, with kind of village volunteers, etc. And they're quite cheap. They kind of cost probably about 30–40p, and they've got very good sensitivity and specificity, or consistent compared to variable microscopy. The downsides are for the HRP2 test, which is the one for Falciparum, it can stay positive for a couple of weeks. So if someone's got symptoms within 1 or 2 weeks of having treatment, having a positive test after that doesn't indicate whether they've got a new infection or whether it's just a positive from a couple of weeks ago. A new problem, or an emerging problem that we're seeing, is that clever parasites have now developed a genetic deletion, HRP2 deletion. This is mainly in South America, in Peru in particular, where they first discovered this. And this seems to be increasing, so it means that there's a potential to get false negative results. And there's been a huge increase in the use of rapid diagnostic tests throughout, used by national malaria control programs throughout Africa and Asia. The third diagnostic test, which I mentioned, was the polymerase PCR, but this is really only used for research and also surveillance. And increasingly where we're trying to eliminate malaria, it is being used to try and look at used as a screening tool at the population level to try and find people with low density asymptomatic infections to try and eliminate the parasite in the human community. So that's diagnosis, and that's moving on to treatment. So as I said, the Plasmodium has been around for ages, 30 to 60 million years at least. They know this because they've found mosquitoes with parasites in their gut in amber, preserved in amber from 36 million years. We've only been around a couple of million years. And the first drug that we discovered was quinine, and that was being used actually in South America, and then discovered by European explorers and exploited. So it was introduced into Europe in the 1630s. So I've just got a question here. Is there a rationale to use antigen testing for initial testing screening children with fever returning from high-risk areas? Would this be quicker and easier? Yeah, I think so. I think, so Casey, yes, I think it's, there's lots of kind of discussion around the kind of role and uptake of point of care diagnostics. I think, yeah, I think there's a good argument for actually having them available in places where we see lots of kids coming back, or lots of patients coming back from high transmission areas. But let's discuss that a bit further later. So the treatment, where did we get to? So then so there was a long period where there was no new antimalarials. Then in the 1930s, we got chloroquine, which has actually now hit the headlines again in the context of COVID. So chloroquine was actually a great drug. It's once a day, it's for 3 days. Actually, for the treatment of malaria, it seemed really, really effective and very safe. But then about 20-30 years after it was first used, we started to see drug resistance, chloroquine resistance. And that started in Southeast Asia. Specifically, whoops, oh no, what have I done? On the border between Cambodia and Thailand, which is where I have done quite a lot of my work. And in those days, so this in the 1950s, most travel was by foot or by boat. And so it took a long time to spread, but gradually it traveled west from the Thai-Cambodian border through Burma, through to India, and finally reached the east coast of Africa, and then traveled across Africa. And what that resulted in was, of course, it takes longer time to recover. It means that people are failing their treatments, going on to develop severe malaria, increased mortality. And it means that people are walking around being infectious for longer and therefore transmitting more malaria. And all that translates also, of course, into increased costs. And there's some nice papers which try to show what the impact of drug resistance was in terms of child mortality in Africa. So that was a bit disastrous. In response, there's been lots of efforts to try and develop new antimalarials. One of the first ones that came along was sulfadoxine pyrimethamine, but that didn't survive very long at all. Drug resistance arose to that soon after. And then mefloquine, and that was developed by the military. So malaria has killed more soldiers than have died in combat. So a lot of the big nations, military, are interested in ways of protecting their troops against malaria, and so quite a lot of the drug development has been by the military. Again, resistance developed to mefloquine quite soon, and that again was seen again in the Thai-Cambodian border. All of this resistance has been seen on the Thai-Cambodian border and then spreading elsewhere. And then finally, it keeps happening. We see the rise of the Artemisin combination therapies, and that's what I'm going to talk about a little bit more. So the Artemisinins were actually were kind of considered the new hope. They're really interesting, actually. They were developed, during the Vietnam War, as the Americans would call it, or the American Wars, the Vietnamese will call it. Both the Chinese and the Vietnamese and the Americans were trying to find new drugs to combat malaria. The Chinese had this massive secret program of going through all their old medications. So this is from I think 600 AD, for treating fevers and malaria. And they found this Xinghao Su, so treatment for kind of fevers, and it was found to be really effective. It's also known as sweet wormwood in English, so it's actually quite common. It's very rapidly killing. It reduces gametocyte carriage, so the bit of the parasite which transmits malaria. It can be given orally, intravenously, and rectally. It's very well tolerated, and it's a once-a-day treatment. So, as we were facing multi-drug resistance, when this was first discovered, it was fantastic. So it just shows that one of the reasons it's so effective is that it kills parasites across the 48 hours, across the whole cycle of the parasitized red cell. so about 40, whereas quinine seems to only really kill the parasites in the kind of middle and later stages. It's a fantastic drug, but yeah, it does have to be given in combination. So we don't have artemisinin alone. It's given always in an artemisinin combination therapy. So it's always given as an ACT. There were lots of studies showing that it was more effective. So this is on severe malaria. This is the 30Apr trial, which was conducted on Asian adults, which showed that there was an absolute reduction in death compared to quinine by over 30%. And this was followed by the Recurrent trial, which was carried out in African children, which showed a massive reduction, well, not massive, but a significant reduction in mortality compared to quinine. Okay, I'll come back to the questions at the end. Oops. So this is actually just showing the kind of the number of studies being done on artemisinins. The very early studies were done by Chinese scientists, but it was all anonymous. So there was no kind of big kind of Nature kind of paper and with a single author. They were all done as a collective kind of communal effort. There was no change in the WHO guidelines, and they weren't being funded despite a lot of evidence. Unfortunately, the Chinese scientists did get a Nobel Prize for it eventually, but there was a lot of kind of delay in getting artemisinins into into policy and being funded, and that's largely because they were much more expensive than chloroquine. This is what I'm putting this in because this is what I kind of spent loads of years of my life doing, was trying to understand why and doing an economic analysis on why using a more expensive drug made lots of sense in terms of reducing drug resistance in the future. But finally, WHO did change its guidelines, and so now the first line treatment for uncomplicated malaria is artemisinin combination therapies. The ones that people will be most familiar with will be Recurrent, which is artemether lumefantrine, but there's a few others, and obviously Artemisinins intravenously for severe malaria. But unfortunately, as most of you are probably aware, quite shortly afterwards, when we thought that hopefully with the ACTs we would have their use for a long time, but not that long ago, we started seeing artemisinin resistance developing again on the Cambodian-Thai border. And it manifested initially as just it took a longer time to clear parasites. So that's kind of, and we were seeing a difference in terms of on the Thai-Cambodian border, it was definitely taking longer than it was taking elsewhere. There's been lots of work trying to understand the mechanisms, and the bad news, it is getting worse. So it's getting worse both in terms of the severity. So people are getting to fail completely, and it's also spreading. So it's now kind of reached probably halfway across Myanmar in terms of the drug-resistant genotypes, and it's now across Southeast Asia. And that's the big concern, is that it's going to spread to Africa. Unlike 50 years ago when people were traveling mainly by ship, obviously people are flying now. And you know, there's concerns, for example, that there's lots of Chinese workers who come and work on construction sites and big projects in Asia, and is that going to be the route of travel? That people are that we actually get it jumping and spreading in Africa. There's lots of questions in terms of whether the mosquito that you get in Africa can actually carry the drug-resistant type parasite that you get in Asia, and lots of research that's going on in that area. Lots of interesting questions, and I'm going to answer them at the end. So yes, spread to Africa would be a complete disaster. I'll talk about malaria elimination. Maybe I'll take the questions now, actually, because I think you've got some interesting questions there. So, question from Thomas: is it an advantage to have a hypertensive feature in relationship to combating severe malaria? I've heard about upregulation of the renin-angiotensin in some high-risk groups to protect against malaria, but could increase risk of metabolic syndrome. Oh, I don't know. Sorry, I'm not sure. I'll have to think about that. Another question: is there a theory as to why resistance is seen on the Thai-Cambodian border each time? That's a really good question. It's a kind of paper I keep on thinking I should be writing, but it's probably where you first get drug resistance is where they first have to switch out to a new drug. So that place is always going to have the longest time with a new drug. So I think there's just a historical precedent that if you've got, so because we had resistance to chloroquine on the Thai-Cambodian border, they were the first to have to switch to SP. And then because of SP resistance, that's where you first had to get to use mefloquine, whereas other countries are still using chloroquine. But there's other reasons. I mean, one is you're more likely to get it in low transmission settings rather than high transmission settings, because in the low transmission setting, people don't have immunity. So if they get infected, they're likely to get sick and seek treatment and take antimalarials. So the parasite population are more exposed to antimalarials. Whereas in a high transmission setting, lots of the parasites are in people who are asymptomatic, and so they don't take antimalarials. So it's likely that at a population level, that a smaller proportion of the parasites are exposed to the selective pressure of being exposed to an antimalarial. So there's kind of epidemiological reasons why you would more like to get it in the low transmission rather than the high transmission areas, then historical reasons in terms of where you've just had lots of exposure, and then more kind of things that we can do things about in terms of how drugs are taken. So one of the things I was really worried about was how much artemisinin was being used on its own as a monotherapy in Cambodia, because it wasn't being sold, it wasn't being given as a fixed dose combination. It was just being given as in blister packs, and people were just taking out the artesunate. There's fake drugs and low and substandard drugs, so people are taking substandard doses. So all that kind of combination of why we're seeing it in the Thai-Cambodian border. Any vaccines available? So I've got a few notes on vaccines at the end. There's the RTSS vaccine, which is the most developed. It's really difficult. There's lots of vaccines in the pipeline. There's one which is undergoing really large-scale population kind of implementation in Malawi, but it only gives you about a third protection, 30% protection. So it's not as good as we would like, but it's better than nothing. And it doesn't last for very long. Would taking antimalarials still protect travellers from fulminant drug-resistant malaria? So nothing's 100%, but it depends. So if you are going to a high transmission area with a sensitive parasite, for example, West Africa, absolutely. By taking an antimalarial, you get protected from getting infected, and therefore be protected against developing severe disease. So it's not that it protects you from getting severe disease, it protects you from actually getting being infected. It's more difficult in places with high drug resistance, but generally the places where we have a high drug resistance, transmission is much lower, so the risk is lower. Do you advise to screen any child coming from endemic areas with flu-like symptoms? Yeah, I think if they are within the incubation period and they've got a fever, absolutely, yeah. So so we see this particularly at the end of holidays. So at the end of summer holidays and Christmas holidays, children coming from endemic areas with a fever, yeah, they should be screened. Also, then there's a question about also in antibiotics now. There's a move away from thinking that longer courses reduce resistance. Why is this not the same for malaria? So it's about the pharmacokinetic and pharmacodynamic dynamics. I can maybe go back to the graph, but you need to make sure that the parasites are, because there's periods where the parasite is not is relatively protected. So that's like, so the kind of, let me see if I can show you that slide again. Basically, you want to make sure that you have you're exposing parasites at all stages to drug. So if you only give them a short course, it may be that some are in a period, are in a stage of their life cycle where they're not susceptible to the drug. And so if you've got a short acting antimalarial, the levels might have fallen to a level where by the time that parasite has reached a stage where it's susceptible, the levels are too low. I hope that, for a longer acting antimalarial like methylquine, you only need a single dose, but for artemisinin, short acting, so you do need to kind of take it for at least 3 days in combination with another drug. I hope that makes sense. And then, what's your opinion of 3 days of screening as per current guideline? 3 days of screening. There can be difficulty in recalling patients, however, in our trust, and we did see a few cases of false negative smears on the first screen, which were later positive. Do you mean taking 3 tests? I think that probably means where if you've got a high level of suspicion that a patient's got malaria because of their symptoms and where they've come from, then it is worth doing it. I think now that we've got both microscopy and rapid diagnostic and the antigen test, I think if both the microscopy and the antigen test is negative, the probability that the patient's got malaria is very low. So unless you've got a very high suspicion, I don't think you need to repeat the test if you're doing both the microscopy and the rapid antigen test. How can we reduce transmission in high-risk settings and not reduce communal immunity? Yeah, that's a really good question, and something that people have really struggled over. It was one of the reasons there was some delay in the rollout of bed nets, because people were really worried that actually if you rolled out bed nets everywhere, then you would reduce immunity, and then you would just push up the age at which you were getting that kind of peak transmission and have more severe malaria. But I think the general feeling is that we have to try and do everything that we can to reduce transmission and have early diagnosis and treatment so that we can treat those who get malaria. And I think that's not, I hope that's kind of, yeah, there isn't any way of being sure. I think it's tricky. Do patients with moderate to mild malaria who haven't received artemisinin need any follow-up, e.g. for recrudescent anemia? That's a really good question. So if you've got an uncomplicated malaria and they've had not just artemisinin, so they've got to have had ACTs, they have to have had artemisinin combination therapy and adhered to it for 3 days, and you've got evidence that they've cleared, I don't think you need to routinely follow them up. Especially if they're from I'm hesitating because I guess if you have someone, most of the patients we see are from places where there's no drug resistance. So most of the patients we see are coming from West Africa or are from Africa, a few from India. We see very few patients who are coming from the epicenter of drug resistance. So if patients are adherent to their treatment, we would expect them to clear their treatment. I think it's always sensible in terms of giving red flags and saying, if in the next month you develop a fever, come back, we want to check you again. But I don't think you need to do it routinely. I hope that. That's just for mild malaria. Obviously, for severe malaria, it's a different. You can get quite severe anemia with severe malaria, so they do need following up. How long after travel would you consider malaria as a potential diagnosis? I.e., what would be the uppermost limit for symptoms? which you could consider. So that again, so just going back to the epidemiology and the different types of malaria. So for falciparum malaria, it doesn't have a stage where it sleeps in the liver. So if they haven't developed symptoms within 2 weeks, it's really unlikely that they're going to develop symptoms, because you don't have that the hypnozoite form. You only have the blood form. Whereas if they have travelled to places where you get for falciparum, having said that, you do get ovale. It's tricky. I guess as a practical rule of thumb, it depends on how worried I'd be, but probably if they're coming back from Africa, I think if they've been back more than 3 months, I think is probably a good rule of thumb. From Asia or Mediterranean, it'd have to be longer because of the long cycles for the hypnozoites. How are we doing time-wise? Almost out of time. So about the parasitemia and clearing, yes, I would want to carry on blood forms. So just if I wasn't clear, so I'm talking about, yes, I would want to make sure that they're cleared. How long after IVR testing should the patients be recalled for a repeat full blood count? We currently bring them back 2 weeks later, but we have a case of postpartum delayed hemolysis only 1 week after treatment. Yes, actually the peak is, so 2 weeks, so the peak, the time for the nadir for the anemia is about a week after treatment. So I would probably bring them back sooner. So I think a week is more sensible. And that brings us to 2 o'clock. I'm happy to stay on for a few more, for a little bit longer if anyone's got any more questions. You're welcome to email me if you want to have any follow-up. Okay, I think everyone's got to go. Great, thank you. Yes, good question about primaquine. Yeah, you have to check their G6PD. You have to check their G6PD status, and if they're not G6PD deficient, then you can give them the 14-day of primaquine. The dose depends on whether they are from Southeast Asia or from South America. If they have got G6PD deficiency, then you can give them a weekly, kind of once a week dose over 8 weeks, but even then you have to monitor their hemoglobin. Does doxycycline help in treatment, seeing as it's used with prophylaxis? It's not great. You know, the doxycycline has got some antimalarial properties, but the other antimalarials are much more effective in terms of the speed at which they reduce the parasite. So I don't think it has much of a role. It doesn't have really a role in terms of treatment. When would you transfuse a hemoglobin? Yeah, 8 is actually quite. Have I got this? Oh, I've just lost it. Oh yeah, I forgot to ask everyone to feedback. I think it might be a bit late. When would you transfuse a patient? Hemoglobin less than 8 is WHO severe malaria, but still advanced and you get more adverse without necessarily seeing mortality. Not quite sure. get more adverse events from the transfusion. I think I would use, it would depend actually on their rate of fall. So if, I think for guidelines, you always need some kind of cutoff, but I think it would depend on the patient. So if there was a patient with a high parasite density, high parasitemia, so for example, if I had a patient with a hemoglobin of 8 and a parasitemia of 20%, I would transfuse them. There may be a patient who had a more chronic anemia and seemed to be, the anemia of, a hemoglobin of 7, who I have reasons to believe had a low anemia beforehand, had a low hemoglobin chronically, and had a very low parasitemia of 0.1% or something. Then was not showing any signs of clinical anemia. Then I might sit tight. So I think I think cutoffs. I think kind of I would always use the cutoffs with my clinical judgment, I think. Oh, COVID and chloroquine. Yeah, it's interesting because it's really hydroxychloroquine. I guess hydroxychloroquine has got less adverse events, adverse side effects to chloroquine. I was a great believer in chloroquine because I think it's actually very safe in the context of malaria, but it's certainly the early, the studies with hydroxychloroquine and COVID-19 seem to suggest that we're seeing significant cardiac toxicity, because I think it's a completely different patient population. All right. I think we've still got quite a few people on. Last chance, but I hope the people that ask questions, I hope I answer. I can't answer. There's lots I don't know, so I'm sorry. But I hope I managed to answer the ones that. Okay, thank you everyone. Bye for now. And do remember to give your feedback.